Okay, good afternoon. This is Trudy Esch talking. We're going to talk about the local maternal child health annual plan for fiscal year 21. Thank you so much for taking the time out of your afternoon to join us today. We hope that this will be really informative, and it will give you some insight into some of the changes that we've been working on for the local maternal child health program. On behalf of the local MCH team, I want to welcome you. In the room right now is myself, Trudy Esch, our team leader. The division director, Carrie Terry, was unable to join us this afternoon, so she is not here, but she sends her greetings. And then my other colleague, Robin Orsborn, is delayed, so she is en route to the webinar right now, and so I'm sure you'll hear her voice later in the webinar. And then also in the room, I have an MPHI colleague, and I'll let her introduce herself.
Hi, my name is Danielle Calloway. I'm with MPHI. I'm kind of going to be answering any questions you have in the group chat about technology. So if for some reason you can't hear or have any other additional questions, feel free to put those in the chat box.
And we are so grateful to MPHI and to Danielle for allowing us to use their platform to record this webinar this afternoon and to make this webinar possible. So thank you very much. So we have a brief agenda for today. We're planning on covering 6 different topics. The first topic we're going to talk about will be the local MCH work group recommendations that came out of our work group that we had earlier this year. We're going to give a Title V overview and talk about some of the Title V legislative requirements that we have to follow in the local MCH program. And then we're going to talk about what state legislative requirements we need to follow in the local MCH program. Then we're going to talk about the budget changes that we're going to be making in the local MCH plan for fiscal year 2021. And then we will talk about the updated local MCH annual plan components that we have based on the work group recommendations. And then we will talk about all of the LMCH plan notification materials that were sent to you last week on March 4th. So let's get started with the work group recommendations. As I'm sure all of you know, we convened a work group in the fall, and we met in October, November, January, and February, so the fall winter time. And the purpose of the work group was to discuss the local MCH program requirements, the work plans, the financial reporting, to identify challenges and ideas for solutions related to the local MCH plan. And we had a call for participants, and we had just an overwhelming response of the number of people that wanted to be involved on the work group. So it was clear to us that people had a lot to say about the local MCH program and what kinds of ideas that they might want to move forward for solutions, and some of the challenges that they might have wanted to give feedback on. So what we decided to do, since we couldn't have a work group of 50 people to be productive, we decided to survey all the local health departments so that everybody had a chance to give their voice to the challenges and solutions that they could find or that they wanted to suggest for local MCH. And so we had a really great survey response, and the survey results were taken to the work group. The work group consisted of 13 local health department representatives and 6 staff from the Michigan Department of Health and Human Services. The work group reviewed all of the survey information. The department staff gave the work group more information about the legislative requirements that we have and why we have to ask for things in a certain way, but yet we wanted to try to be creative in how we might change things so that with our local MCH processes. So in the end, as I said, the work group met for 4 times, and they provided input on the processes, the plan, the year-end report. We created a guidance document, and people gave us critique on the guidance document. We addressed additional concerns about LMCH related to the timeline, what kind of technical assistance was available, peer sharing, and other kinds of LMCH processes. And we really worked with our internal partners about how we might make some substantive changes systematic changes related to the budget. And so we were looking at some budget proposals, and some of the work group members actually piloted our budget proposals so that we would make sure that they worked efficiently for local health departments and that we were not going to have any unintended consequences related to something that we proposed. And I would like to say that as we put together these changes, we hope that you see that they're more efficient and that it makes more sense for the local MCH program. We do plan to reconvene our work group in the fall and seek some additional input from all of you to make sure that the updated processes that we're implementing are have their intended response and that they're more efficient for you. Or if we need to make changes, we can start thinking about them in real time so that we can nip any challenges in the bud, so to speak. So the work group came up with sort of 9 recommendations. The first recommendation is that we are reducing the budget projects in the EGRAMs from 5 projects to 2 projects. And we are really excited about that, so I hope you all are cheering. We have you on, everybody on mute right now, so I can't hear you cheering, but in my head, I just hear you jumping for joy. We heard loud and clear that the local health departments want to continue to have the flexibility that they need to use the local MCH funding for the local activities that their needs assessment directed them to. We are retaining the flexibility to use promising practices as well as evidence-based and evidence-informed strategies in the work plans. We streamlined the local annual process and simplified the year-end reporting. And we are retaining the performance measure structure that we have one work plan for each performance measure. And then we heard loud and clear that it was very cumbersome to have the pyramid of services in the action steps of the action plan and in the allocation table. So we have eliminated the pyramid of services in those places. We heard that people wanted more technical assistance from the local MCH team, including kind of webinar office hours. So we, in addition to doing this orientation to the local MCH plan, we plan to do an orientation to the local MCH report. We're going to be offering some webinar sort of office hours. We're calling them learning labs that we'll be doing this fall that will focus on the annual plan and components of the annual plan. These are all optional things. So if you want to join us for those, we're certainly available to help you with those. The LMCH team is available at any time that you have questions or concerns or that you need extra consultation. So you just need to let us know that you'd like a one-on-one webinar or a phone call if you need some extra help. So we're happy to give extra technical assistance as it meets your needs. People wanted more opportunity to do peer sharing, and we are having our first annual LMCH coordinator meeting later in the spring on April 30th, and so we're devoting the afternoon time for sort of one-on-one peer sharing among your peers, and then we've also got time for some a panel of your peers that will be doing some sharing in the morning. Another thing that we did was we developed a timeline. And when we developed the timeline, people actually asked us to do some revisions to make it be even more user-friendly, so we did that. And people said that they really needed a guidance document to give instructions for how to complete the annual plan and the year-end report. And so Robin and I have been working feverishly on that, and we were able to complete that and get that out to you. Let me see if I had anything. We also asked the work group members to share the work group recommendations and the work group processes with their MELF forums. And so I know that some of the work group members did that. And we sent out a communication about these final recommendations to the health officers through MELF. And then we also sent them out from the LMCH team to the work plan, local MCH work plan contacts and the finance people that we have. So let me pause for a minute and see if there are any questions about the work group recommendations, or if you've got any questions, comments that you would like to make at this time. Can they ask the question just on the phone, or do they have to type it in?
No, feel free to unmute yourself or type questions into the chat box if you aren't able to talk right now.
I wanted you to know that my colleague Robin has joined us, so I'll let her say hello before we move on.
Hey, what's happening? I'm here temporarily. This is Robin Orsborn. I am the local maternal child health and Medicaid outreach consultant for the department.
I don't hear any questions, so we'll go ahead and move along. There's opportunity for questions throughout our presentation today and at the end as well. So feel free to ask a question during our next kind of question slide. There's quite a few question slides. Okay, so we're going to talk about now the Title V overview and legislative requirements. One thing that we noticed during the work group is that it's very important for people to be able to understand the Title V MCH block grant requirements as well as the state requirements, because it helps you to understand the rationale for why we have to ask for some of the things that we have to ask for. And people in the work group found it really to be helpful, so we thought we would share it with you during this webinar. This slide you may have seen before because it's a favorite slide of mine, and so it just talks about the Title V Maternal Child Health Block Grant. It's the longest public health legislation in U.S. history. It was originally authorized with the Social Security Act in 1935, so this August will be the 85th year that it's been enacted. It's the nation's oldest federal-state partnership, and it's the only federal program that's entirely focused on improving the health of mothers, infants, and children. And of course, since 1935, there's been changes to the Title V MCH block grant. Excuse me, in 1981, it became a block grant, and then there was new accountability requirements that were added in 1989. And then in 2015, there was a major performance measure framework change and introduction, and trying to consolidate things and make things better at the federal level, try to make more efficiencies at that level. So the Title V block grant has several goals that you can see at the right-hand side of the screen. Access to quality care for mothers and children, health promotion efforts to reduce infant mortality and prevent diseases, increase the number of children who are immunized, make sure that women have access to comprehensive prenatal and postnatal care, making sure that there's health assessments and follow-up in diagnostic and treatment services, making sure that there's access to preventative and rehab services for children in need of specialized medical services, and to make sure that Title V is family-centered, community-based, in a system of care that's coordinated for children with special health care needs. So that goes along with the vision and mission that Title V has enacted. So they're very similar, but the vision is to envision a nation where all mothers, infants, children aged 1 through 21 years, including children with special health care needs, and their families are healthy and thriving. I will add that the Title V block grant is a formula grant that's based on the proportion of low-income children in a state compared to the total in the U.S., and so all the states get an appropriated amount based on that formula. And the overarching goal is that focus on health promotion and reduction of preventable disease and access to care. These Title V requirements that we're talking about are requirements that the state must do in order to receive the Title V funding. At this time, we don't have a recommendation that the local health departments have to meet these same requirements. So I just want to make sure that you're aware that these are our state requirements to get the funding. So the first slide that we're talking about the funding is the 30-30-10 rule. So basically what this means is that 30% of the funding must be used for children with special health care needs. 30% of the funding must be used for preventative and primary care services for children 1 through 21. And we can only use a maximum of 10% of funding for administration of the block grant. And for every federal dollar every $4 of federal funds, I cannot say that. For every $4 of federal funding, it must be matched by $3 of state funding. And as I said, it's not imposed currently at the local level. However, when we look at the total of money that the state of Michigan has appropriated, 37% of that funding goes toward local maternal child health programming. And since such a big chunk of change goes to local MCH really does need to make sure that we as a state, not individual health departments, but we have to meet this minimum of 30% funding used for preventative and primary care services for children ages 1 through 21. Because if we don't meet that in local MCH, we won't meet it at the state level. And it's not an option not to meet that 30%. The federal government, it's a hard stop. You must meet that requirement or you can't submit your application annually. So it's a very big deal, that 30%. So this is just a pie graph to show that local MCH gets a big chunk of the funding at 37%. And the other big chunk of funding is the medical care and treatment for children with special health care needs. And then there's a variety of other things that, besides those two programs, that Title V funds, such as reproductive health, lead poisoning prevention, immunizations, the regional perinatal quality collaboratives, safe sleep, oral health, maternal mortality surveillance, the PRAMs, and other MCH initiatives. Obviously, the Title V funding isn't the only source of funding for many of these programs, but it helps to give additional revenue to help those programs succeed. These are some of our state requirements related to programming for as Title V requirements. So every state, through their 5-year MCH needs assessment, must identify 7 to 10 state priority needs across the 5 population domains. Every state must choose at least one national performance measure in each population domain. And HRSA defines which population goes to which national performance measure, and that's coming up in a slide soon. And if the MCH needs assessment that the states do demonstrates that we need to have additional performance measures, states can also create state performance measures to address other needs within the state. And then each state priority need must link to either a national performance measure or a state performance measure. Again, these are state requirements. We're not requiring locals to do these at this time. So the national performance measures available for states to choose from are 15, and they're listed here on the slide. And as a result of our current 5-year MCH needs assessment, which is due this summer, we have changed the performance measures based on our assessment, and so these are the national performance measures that are selected. Low risk cesarean delivery, which is a new one, breastfeeding, safe sleep, bullying, another new one, transition, and preventative dental visit. And so you might notice that we've retired a couple of our performance measurements. In the former iteration of our plan, we had well woman visit, and that's been retired. We had adolescent well visit, that's been retired. And we also, sort of longer ago, had developmental screening, which was retired a couple years ago, and medical home, which was retired a couple of years ago. All of these things, if your local needs assessment show that you want to use those performance measures, you can use them in the local MCH annual plan, but use them as a local performance measure versus a national performance measure. We also have 6 state performance measures. So here on this slide, you can see all the performance measures that the state is using. You'd think I would know how many that are federal. 6 national and 6 state priority needs. So we have retained some of our state performance measures that we had before, such as lead. We broke down immunizations by children and by adolescents. We have medical services and treatment for children with special health care needs. And then we added 2 more. One is about intended pregnancy, and another is related to behavioral and mental health. I know that this slide is very hard to see, and I wanted you to know that this table, and actually sort of a longer table that shows it by domain, is in the guidance So if you look in the guidance, which is attachment C from your notification email about local MCH, it's in the appendix, Appendix A on page 10. So you'll be able to see it a little bit better in the appendix. We also have state reporting requirements related to the type of population served, the types of services that we use, and health coverage. So so these forms that we have to fill out right here, we get that information from a variety of sources, all those programs that have Title V funding, local MCH, children with special health care needs, and all those other programs that we talked about, like immunizations and lead and family planning, et cetera. So let's make you aware of the state Michigan legislative requirements for local MCH. Each year in the annual appropriations bill, there's money that is appropriated for MCH services. And so it's in the appropriation bill that is signed into law. Go to the next slide. So this just shows you, I've highlighted the local MCH services line. So that's how much money is appropriated through the state legislation for local MCH services. Local MCH services includes a few more things besides local MCH, but this is where the local MCH project pot lies in the appropriation bill. And then there's also a section in the appropriation bill that talks about the reporting that we have to do as a state receiving this funding. So we have to give a report about the funding allocations. We have to talk about the actual number of women, children, and adolescents served, and the amounts that we expended for each of these population groups for the immediate preceding year. We have to give a breakdown of the expenditure of the funds between urban and rural communities, and we have to make sure that rural communities are getting some of the funding. So this is an example of the fiscal 19 expenditures. We're just wrapping this up. So these were our projected expenditures. And you can see local MCH services is the same amount of money that was actually appropriated that I had highlighted before. So are there any questions about the legislative requirements that the state has to do it for the federal Title V funding or to receive the funding at the state level? Do we have any in the chat room?
No.
No.
Oh, no questions. Understanding the background for those requirements is very helpful. Thank you.
Oh, good. I'm glad that it is helpful. I think I'm going to try to point out as we move along some of the things that we retained in the annual plan as a result of those requirements. If there's no other questions, we'll move on to the local maternal child health budget update. So the budget categories have changed over time. So you might remember back in fiscal 16, we had 12 categories of budget categories for local MCH, listed on the left there. And then in 2017 through 2020, the budget categories were reduced to 5 categories that were by type of service. And also in 2017, we started doing work plans by these types of services as well. But our big news is that we were able to reduce the local MCH projects in eGrams from 5 projects to 2 projects. And the 2 projects that we'll be using for fiscal year 21 are called MCH Children and MCH All Other. And you might be able to guess that the reason why we wanted to retain a budget category for children is it helps us to track the 30% of children that we need in that 30-30-10 rule for the federal Title V requirements that we have. And so we're not so worried about the children with special health care 30% because our colleagues in children with special health care services easily meet their 30%. But as a state, we want to make sure that we're counting all of the children that we're serving and expending funds to. And so this specific project related to children will help us to be able to do that. So the work group did recommend that we follow the 2 projects in eGrams. We considered another model and decided to go with the 2 projects. As has always been the case, the projected expenditures in the projected count and allocation table need to match the budgeted amount in the MCH source of funds line in the budget application. So you can see we subtotaled children, we subtotaled all others. That's the subtotal of all others will go on the source of funds line in the MCH all other, and the subtotal children will go in the MCH children. And again, we heard loud and clear that it was really cumbersome to break things down by the pyramid of service, so that has been eliminated in this table. This table is, I want to say, sort of turned upside down from how you might be accustomed to seeing it. Previously, we had the count and the amounts sort of going across instead of in the column. And so now we have the population classification on the first column, and then we have the count and the MCH allocated amount for each population classification, and you can see they're color-coded there. And then we have 5 columns where you would break these down by the performance measures. So whatever performance measures you select, you can put there. So if you only select 1 performance measure, obviously you'll only use 1 column. If you select 6 performance measures and there's only 5 columns, you'll have to add a column. We did set it up so that you can select the table by using the hashtag and then hit the F9 key, and the totals will come up on the far right columns. But if you have to add a column, it will mess with the table calculations, and you'll have to do them by hand. What else do I need to say? Oh, I know what else I wanted to say. Let me make sure that I'm not jumping the gun. You might notice that there are more populations than there have been in the past. And this, again, is because of the state and federal regulations. So, for example, in the federal regulations, they asked us to tell them how many pregnant women were served. Is it projected or does it say pregnant in there? I can't really read that very well.
It's projected pregnant.
Oh, it says projected pregnant. I'm like, oh, good. Oh, that's because pregnant's in the turquoise. Sorry, my old eyes are giving me a little funny wording, or funny, I can't see well. So anyway, but the pregnant women are something that we have to report in the federal guidelines and are reporting, and so we've added that there. We also have to report on infants, but in the state guidelines, they want us to report on children 0 to 9 and on adolescents 9 to 21. So the way that we have to give counts at the state are different than that we have to give counts at the federal level. So we're trying to accommodate by having all these different population levels. We did have, I think I mentioned this already, that we had 5 health departments trial our budgets and the allocation table to make sure that there weren't unintended consequences. So we hope that by being really careful and really carefully considering how this might impact you, that it's going to end up being better for everybody. So we hope that's true. There's a timeline at the department for LMCH budget requests, and this is dictated by other departments other than our department in LMCH. So our request for fiscal year 21 for eGrams projects is due in early March. It's already past due. And this allows the grants division to be able to get the eGrams projects up and running and ready and open in the budget application. And so, of course, we do not know what you're going to allocate for fiscal year 21 because your plans aren't due yet. And so what we did, to be very transparent, is that any health department that currently has a project of direct service children or enabling service children, we then made a request for our new project, MCH Children. And any health department that has a request for MCH All Others, they have funding currently in either the direct service women, the enabling service women, or the public health function project. This isn't total, this for local MCH, this isn't set in stone. So if we open two projects, both projects, but you don't need one of them, that's okay. All you have to do is just leave it alone, and it will go away after they get all the contracts signed, sealed, and delivered. But please do not, if you're not going to use the project, don't put like $1 of MCH funds in there, because it will mess the whole system up, and then you'll have to do an FSR on the dollar. It just is crazy. So if you don't need it, just leave it be and let us know that you don't need it. If we only requested one project for you and you need both projects, just let us know, and we will work to get that open for you for the budget application. No, I don't have questions. I have this slide. Did it not come up? There it is. This is a table of Excel spreadsheet that shows you what we asked for the budget categories to be open. So many health departments have both of them open. Some of them have only one of them open. And the amount of funding that is in each of the projects is related to what I said before. If you had a child project before, I added them up. And we're asking for the child project to be open based on the funding that you had for fiscal 20. And then anything else, we added up and put it in the all other category. These funding amounts, if you're going to shift and you don't want to use the amount of money that we have in one of these funding projects, that's fine. You can just make the adjustments that you need to in either of the projects. But we wanted you to be aware of how we had to do that, because we have a very early timeline to get that in. Any questions on the budget?
Feel free to comment in the chat box or unmute yourselves.
Well, you guys are a really quiet group today. We got a question? Good.
Regarding the allocations table, we do some population analyses where the numbers come in handy already broken down into age groups that do not align with child or adolescent categories. What is the solution for filling out that table in circumstances like this?
Danielle, can you go back to the this slide? Yeah, that's the one. So, and the question was that you do things that are population related, that they don't fall into any of the individual categories. And so you can see the very bottom category is called population. And so it sounds to me, without knowing a lot of information, that that's where you would align your work, is in that population category. That's more for aggregate kind of work. It's for if you're counting community members or providers or staff development, or if you're doing a media campaign and doing media analytics, or if you're doing some aggregate data collection and analysis from the EPI department, that's where those kinds of things would go. Does that help?
Wonderful, thank you.
Great.
And then we have an additional comment. Great information. I suspect I will have plenty of questions once I try things out. Do you have a sample?
As a matter of fact, it's a great question about the sample. Robin and I, as we said, we were going to, one of the recommendations was to do some technical assistance work with you. And so we have planned a series of learning labs. And what we're doing is we're breaking down the LMCH plan, and then we have a time for a budget where we're going to give sort of a sample plan and how to lay it out. So we do have that. So we're working pretty tirelessly trying to get some additional samples for you. So that should be coming in the future. Thank you for your questions. If you have more, feel free to chat them in, and then we have another question time again after this section. So now we're going to talk about the maternal child annual plan, the updates, and what those updates are. So first of all, the local MCH focus, because of the Title V focus, is that we are supporting a data-driven process. We're really looking at outcomes and outcome-oriented process. We're looking for things to be either evidence-based, evidence-formed, or to have a promising practice strategy. And that doesn't mean that you can't use some other kind of innovative strategy. Other kinds of innovative strategies can be allowable with an additional proposal that outlines a timeline, goals, objectives, strategies, and an evaluation method. And we've had this in the past as well, and we've actually had a couple of health departments who have taken us up on trying out some innovative strategies with local MCH funding, so this is something that we're continuing. We are really focusing on trying to increase the efficiencies for local health departments in working with local MCH, and those local efficiencies will not only help you at the local level, but I think that they're going to help us at the state level. Just the sheer magnitude of only having a maximum of 2 budgets for 45 health departments versus up to 5. I mean, some people only pick one project, but many health departments pick 5, so there's a lot of projects to review. So just that, if we only did that, that would really increase the efficiency. So those are the things that we're kind of focusing on. These are the work group recommendations related to the annual plan. They're a little bit more specific than I gave you in our opening slides. First of all, we tried to reduce the redundancies that were in the narrative section, so we eliminated those. We eliminated the strategic priority table and the strategic priorities in the work plan. People told us on the survey that we did in the fall that they liked the goals, objectives, metrics, the performance measure structure in the work plan, so we retained those. We did make some work plan changes that you'll see as the slides continue. We eliminated who the stakeholders are in the work plan. We changed the anticipated outputs to deliverables, and we eliminated the work plan, the pyramid by service in the work plan. Now, the types of services is a federal requirement that we need to report on, so we couldn't just eliminate it entirely. So what we proposed to do, and the work group agreed, we looked at it, is just to add a separate table of types of service. So you'll see that new in the annual plan. So this is what the simplified LMCH annual plan looks like, and of course it's very small here, so you might want to refer to your attachment B from the local MCH notification, and I also put it on the email reminding you about this webinar. So we sort of tweaked the language that we had in question 3, which is about the capacity of and including women, children, and youth in decision making. We're really looking at how you continue to have families involved, which is what Title V wants to look at. In question 2, when we talked about your needs assessment update, we are asking for the date of your most recent needs assessment. Obviously, we did the needs assessment process in 2017. Many of you are on different timetables for your MCH needs assessment, and we just like to see kind of where you're updating it, how you're updating it, and sort of the date of your most recent needs assessment. And if you did a new needs assessment, just what your top priority needs that arose can briefly be stated in that second question. As I said, we eliminated question 4, which was about the strategic priority in the table. And we also tweaked the question that comes after this table about the justification for choosing the performance measure and the budget justification. So we just tweaked them a little bit. This is what the simplified work plan will look like. And as I said, we retained the things that people said that they liked. So we retained the goals, we retained the objectives, we retained the metrics, but we changed the data column to, instead of just saying data, where you would give your metrics, we called it relevant data, because some people were feeling that we were asking for sort of too much data all over the place. So we just want the relevant data related to the performance measure in the work plan that you're doing. We also retain the evidence-based strategies column and the action step column. And then as you can see, we changed the outputs to deliverables, got rid of the stakeholder. And then we are going to, you'll see that the year-end reporting will be simplified. We moved from 2 columns just to 1 column, and we changed the questions to be a more simplified 4 questions. So we hope we simplified the count and allocation table. It looks colorful, and there's a lot of lines for the population classifications, which I've already talked about why we decided to do that. So we have the children, the adolescents, the children and youth with special health care needs, the women, pregnant women, infants, other individuals, and a population component. And so we gave a brief definition of what those categories are underneath the count and allocation table, and there's information in the guidance that we did that gives you information about that as well. Is there anything else I need to say about that? Okay. This is the new table that we had to add, the reporting of the table of services, because the federal government requires that we as Title V recipients must report on the types of services, whether they're direct, enabling, or public health services. And so the small table that's there with the 3 columns literally is lifted from what we have to report on in the Title V application and report. We just added, just for this slide, the pyramid of services to remind you what they are. They're not in the report, actually, so that the direct services are at the top of the pyramid, the enabling services in the middle, and then the public health functions, which are related to the essential services. The federal government has under the direct services that they want to know the amount expended for preventative and primary care services for pregnant women, mothers, and infants. And then they want to know the expenditures for preventative and primary care services for children that fall under direct services, and then direct services for children with special health care needs. Somebody asked about the sample, and for our work plan, actually, or our work group, Robin and I were trying to do a mock-up plan. And so as we were doing the mock-up plan and we were filling out this particular table, we felt like we needed to do like this little worksheet on the bottom to explain to the work group how we came up with the amount of money that we had in this particular table related to the allocation table. And so we put this worksheet together, and the work group actually found the worksheet to maybe be helpful. So it's an optional worksheet. We just put it together so that when we told people how we came up with numbers in the table at the top, that people would understand it. So if it's helpful for you, you can use it. If it's burdensome for you and you don't want to use it, that's okay. But what we do need is that top table filled out. And this is not a new table. This is a table that's been in the plan for a couple of years. So we put together that evidence-based document, which is now attachment D, that has been updated. And so if you can find your evidence-based or evidence-informed strategy in that particular document, you can just use that in the work plan column that's for evidence-based strategies. But if you, certainly that document that we put together isn't an all-inclusive evidence-based document. There are many evidence-based examples, evidence-informed promising practices that we did not include in that table. And so if you want to use an evidence-based or informed strategy that's not in the document, you just need to give us the reference of what your strategy happens to be on this particular page. But if you only use strategies from that attachment D, you can leave this page blank. So most people honestly don't use this particular reference table, but it's there if you need it and if you need to use extra literature review to report what you're doing. So any questions about the LMCH annual plan changes that we've implemented, comments, questions, concerns?
So we have one comment right now in the chat related to the needs assessment. In 2017, we had to follow a specific process from MDHHS. If our local public health department is doing a needs assessment currently, will that be acceptable?
That's a great question. Thank you for bringing that up. Absolutely, you can use whatever MCH needs assessment, well, it doesn't have to be MCH, whatever community health needs assessment that your health department is doing that includes an MCH component can be used in the local MCH report so that we can understand how you're doing ongoing needs assessment. Some people do just a separate MCH needs assessment, but more people do needs assessment maybe with community partners with their hospital when they do the community health needs assessment that hospitals have to do every 3 years, or some people have a, every 5-year process that they have to do, or some people are doing accreditation and they have to do MAP assessment for their accreditation. So there's many kinds of community health assessments that people are doing across the state. And so whatever community health assessment that you're doing that relates to MCH, by all means included. I mean, it might be broader than MCH, that's fine. No.
Any other questions?
Okay, well, we'll move on to the local MCH annual notification materials that we sent. So last week on March 4th, you should have received by email a notification that included a letter from our boss, Carrie Terry, that talked about the local MCH notification. The local MCH plan is due much later this year than it has been due in the past several years. It's due on May 8th. Oh, shoot. That's bad that I don't remember. I have it right here. I don't want to give the wrong date. It is due on May 8th. And then the notification had several attachments. So the first, we'll go through all the attachments that are down here through the slides. So the first attachment is the budget allocation, and this budget allocation is the same as that you've had for the last, well, as long as I've been at the health department. I mean, at the state health department. So that is unchanged. And then we just went through basically the attachment B, which is the local MCH annual plan. We went through it sort of briefly, and in our future webinars, our Learning Lab webinars, will break that down more specifically. Attachment C is our new guidance document that we put together. This is the guidance for our annual plan and for the final year-end budget report. And so you can see that we have a table of contents there on the left, on the right. I do know my right from left. So you can see that we talked a little bit about processes that we do with local MCH. And then there's a whole section too about the local MCH plan instructions that talks about how to complete each part of the plan. And then there's section 3 is about the year-ending reporting instructions. And then we have a section on logistics. So it seems silly, but like saving the document and naming the document appropriately. If you name the document in a funky way with certain characters, when you upload it to eGrams, we can't always see what you upload because it has a special character in there, and eGrams doesn't like that. So it's kind of fussy about that. We gave some financial logistics in there, and then some eGrams tips. And then we have a series of appendices in this particular document. The first appendix is the updated new national and state performance measures. We have a whole appendix on all the definitions that we use throughout, the document and obviously through the LMCH plan. And then the last appendices, the appendix C, D, E, and F are things that we've put together in years past, and we added them in this document to be comprehensive in the guidance document. And then attachment D is the evidence-based strategies by performance measures for local MCH. And this is our version 8 from March of this year. What we did was we made sure that we updated the document so that it followed the new performance measures. So you can see the 6 national, 6 state performance measures that are there. And then if we retired a national performance measure, we moved it down into the local performance measure so that we didn't lose some of those strategies. And so each performance measure, you can go to the next slide. Each performance measure has a little brief overview about the performance measure. So you can see on the right side, this is the example for safe sleep. And then we have some potential evidence-based or informed strategies that you can use in your work plans related to safe sleep. So you can just lift one of these and put it in the work plan, and there's your strategy. We also have given references if you want to take a look at any of the references that are related to the performance measures. So we hope this is an easy way. We know that sometimes it's really hard to first of all, to find the time to do a PubMed search or some other kind of library search to get some good information about strategies. And second of all, it's hard if you are not affiliated with an academic institution or that you don't have some other paid subscription to libraries to even access the journals. So we tried to get that information for you. We tried to look at a lot of references that actually have publicly available data that you can download a PDF, but that's not always the case. And then our federal partners have done some great work on the evidence-based documents, so they've pulled together some potential strategies as well. So we hope that's a helpful resource for you. We've been talking about the learning labs that we're going to be doing, and so that's what attachment E is. The first line, well, actually, I guess it's the second row. First row is on my column row, or my heading row, but the kind of the grayscale line row there is this orientation that we're doing today on LMCH orientation. And then we're going to be doing 4 learning labs over the next 2 months related to the LMCH plan. And so that's when the 4 learning labs are. They're on the schedule there, March 25th, April 8th, April 16th, and May 6th. And the web meeting address is at the bottom of the document. The plans will be due on May 8th. The peach color row talks about that's the LMCH coordinator meeting, and we'll be talking a little bit about the work plans during that meeting as well. All of these technical assistant learning labs are optional labs for you. People wanted more information and they wanted more technical assistance, so this is one way that we are trying to be able to provide technical assistance for people in a kind of simple, unobtrusive way. But if you have additional questions or you need extra consultation that is outside of these hours, we're certainly available to meet with you, to talk with you on the phone, to have a one-on-one webinar, whatever it is that meets your needs to help you with things, we're happy to help you. And this last attachment that we sent is this timeline. And originally we were using this timeline as a draft for our work group so that they would understand when things might be due for the fiscal year 21. And as we shared it with the work group said, "Wow, this is really a great document. Can you please add fiscal year 20 into the document?" So we added fiscal year 20 into the document, and then as 21, encroaches over a couple of calendar years, then it seemed funny not to add 22. So this is 2 calendar years worth of when things are kind of due or when to expect things related to local MCH. This timeline is subject to change. Excuse me. The local MCH team does not have any authority to say when the budget amendment cycle requests are due. So we are dependent on another one of our departments to give us that information. So some of these things are subject to change. So it just depends on if the grants division continues to have their same cycle, for example. One thing that the grants department did was changed the final FSR due date. It's traditionally been, over the last several years, December 15th, and the comprehensive agreement for fiscal year 20 moved that deadline to November 30th. So as a result, your year-end report will have to be due a little bit earlier than it was last year in order to meet the year-end budget FSRs, final budget FSRs. One thing that's really critical is that all contracts have to be fully executed by September 30th before the start of the fiscal year, before you can begin any work on the contract. So if your contract is not signed until October 5th, the first 4 days of the month can't be counted. You can't do expenditures until it is signed. So it's a very firm deadline. So any questions about any of the LMCH plan notifications?
So we have one question in the chat right now. Will the learning labs be recorded so we can listen in if we are not available on those days?
I'm sorry that the learning labs will not be recorded. We are going to be giving a little bit of information for the beginning 20 to 30 minutes, and then the rest of it is going to be sort of open question and answer for any questions that you have. But we will compile the questions that we get so that we can send them to people, and we can send the materials that we have for the learning labs to everyone.
Okay, thank you. Feel free to add any other questions you have in the chat or unmute yourself to share them verbally.
So any questions about anything that we've covered today, or something else burning that we didn't discuss today that you need to know? We're happy to answer any questions that you have.
Do you like the changes? Do you hate them? Not sure?
Thank you to all that have participated in the work groups. It appears that you all have done a nice job simplifying and explaining things. I like to program.
Great. Oh, nice to hear.
Was that on the good track? The changes seem great. I hope that we will feel the same way once I operationalize them.
We hope so too.
Yeah, really.
I also appreciate 2 programs, so well received.
We thought that was a really big win for us to be able to go from 5 to 2.
Yeah, we were dancing a happy jig.
Mm-hmm. We went in all ready to try to fight and explain why we needed it, and they just, okay.
Is there a document that shows how each of the local health departments use their MCH funds?
Not really.
There really is not a document that tells how each of the health departments use their funds, but that is something that we're having a local MCH coordinator meeting, and that is something that the planning committee talked about, that people really wanted to share what other health departments were doing. And so we're trying to, we're going to have an afternoon session that does something around that. We're trying to kind of work on some logistics on how to make that happen. But that's our plan in the afternoon, that people really want to know what other health departments are doing. Is there a way that people can be collaborative? How can they peer share information, learn from each other, maybe work together across jurisdictions? Those are things that people were interested in, and so we want to make that happen in the afternoon. I will say that some people said, why don't you just give us a work plan and tell everybody they have to do the work plan, and that will be that. But other people are like, no, we need to have the flexibility. And we have discovered over our years working in local MCH that there are 45 local health departments, and it really is, administering local MCH is like administering 45 single block grants, because everybody does things differently, and everybody, even if you do the same performance measure, there's a different twist in each of the performance measures on how they're implemented at the local level. So that's what makes some of, trying to get a local MCH plan for 45 different block grants is challenging. So we really hope that there's a lot more efficiency in how we've arranged things going into 21. So those are some of the challenges, I think, of the grant. Anything else? We certainly planned for a lot more questions and comments and concerns, so I don't think that people will feel horrible about having some extra time added back into their day. But I do want you to know that as questions come up, if you didn't think about them here, everyone has our contact information, which is the last slide. So feel free to use our maternal child health at michigan.gov, MDHHS-maternal-child-health at michigan.gov, and we'll get back with you. Again, we're happy to chat with you on the phone if you would like to, if you want an individual webinar. We don't want you to struggle. We're here to help you, so reach out to us. We're happy to help. And we really appreciate the time that you've taken to listen to our webinar today. We look forward to working with you and your team as we implement this new process. And I want to remind you that we really are looking forward to.
It's just about the webinar being important.
We are going to ask for some extra feedback once the fiscal year gets started to see how this process worked for you, and if there's things that we can do to make it more efficient, or if we're doing, if we've made the changes that we hope to make it more efficient. We want to hear from you, so you can look forward to getting another survey or giving us some feedback to make sure we're on the right track. We'll hang around here for a couple more minutes in case if there's any other questions.
Also, feel free to talk to us. You can unmute and just chatter away.
So to answer the question about the webinar being recorded, the webinar is being recorded and will be shared via email later.
Yes, we can. Yeah, we will get the link to the recorded session, and we can share that with you. We'll send it, at this point we have to send it probably through the, we'll send it to the person that's listed as the local maternal child health contact on the plan. We'll send the link to them. I don't see any other questions being chatted in, and we don't hear any questions. So again, thank you so much for listening to us today, for the questions that you did chat in. We appreciate, and feel free to reach out to us as you need to, and enjoy